good afternoon, good evening, wherever you are, and welcome to today's webinar titled Management of Sports Injuries. My name is Yara. I'm a Customer Success Manager at McGraw-Hill, and I'm delighted to be hosting today's session. Before we begin, let's take a moment and see who's joining us today. Please feel free to type in a quick hello in the chat and let us know where you're joining from. Also, just sharing a quick housekeeping notes before we get started. You can activate captions by clicking on the CC button at the bottom of your screen and selecting your preferred language. The webinar is also being recorded, and the recording details will be shared with all the registrants afterwards. With that, let's move on to today's session and our distinguished speakers. We're truly honored to be joined by two world-renowned leaders in sports medicine, Dr. Peter Brukner, Dr. Karim Khan, co-authors of the leading title, Clinical Sports Medicine, Managing Injuries. Dr. Peter Brukner is a sports and exercise physician and Doctor of Sports Medicine at La Trobe University in Melbourne, Australia. He's had a distinguished career spanning elite sport, clinical practice, and academic leadership. He was a founding partner of the Olympic Park Sports Medicine, including a team doctor for Australia at both the Olympic Games and FIFA World Cup. He's also held major international roles, including head of sports medicine and sports science at Liverpool Football Club, and later serving as Australian cricket team doctor. His contributions to sport and medicine have been widely recognized, including the Medal of the Order of Australia in 2006 and the Victorian Government's Outstanding Contribution to Sport Award in 2024. We're also delighted to welcome Dr. Karim Khan, sport and exercise physician and doctor at the University of British Columbia in Vancouver, Canada, and scientific director of Canada's Institute of Musculoskeletal Health and Arthritis Research. Dr. Khan is an internationally respected leader in sports medicine, research, and education. He served as editor of the British Journal of Sports Medicine from 2008 to 2020, shaping global discourse in the field. He has received honorary doctorates from the Norwegian School of Sports Sciences and the University of Edinburgh in recognition of his contributions to research and education. He is also an Officer of the Order of Australia, awarded in 2019, reflecting his outstanding international impact in sports medicine. Together, Drs. Brukner and Khan have made an extraordinary contribution to clinical practice, research, and education in sports medicine, and it is a privilege to have them both with us today. Dr. Brukner and Dr. Khan, thank you very much for joining us today. We're really looking forward to hearing your insights into contemporary approaches in managing athletic injuries and how evidence-based practice continues to evolve in real-world clinical and sports environments. With that, I will now hand the floor over to you.
That's great. Thanks a lot, Yara and Scott in the background there. It's great to be with folks on this webinar, and we're really looking forward to any comments and questions. So please don't be shy. It's a very safe place. Use the chat for comments or question and answer as you go through. So Peter, good day, as we say in Australia.
Hi there. Yep, it's lunchtime in Melbourne, Australia. Yeah, we're pretty happy at the moment. You hosted in Vancouver our soccer team on the weekend, and they had a great win in the first round of the World Cup. So I was going to wear my Socceroos shirt, but I thought, no, that wasn't very professional, so I've decided to not to. But no, it's been a good week in Australian sport.
Very good. Well, you're looking good there with the library in the background, and people might be wondering if that's a fake library, but I can assure them that it's a small part of your real library, and it's great to be with you, as folks will catch on this call. So I live in Vancouver in Canada, and I have done since 1997. So Peter and I have worked together in these different countries over the years as we've worked on the books and other projects. So we're looking forward to hitting some hot topics, as you know, and feel free to put hot topics into the chat. Any questions you've got. But Peter, we've obviously planned this a bit, and we're going to go through some hot topics. And if someone said to you, "What do you think? Three big topics are at the moment," what would comes to mind for you?
Well, there's lots of big topics at the moment. I think, I think at the top of the list nowadays in sports medicine is concussion. I mean, it's especially in the contact sport world. I mean, it's a massive issue, both in the in the prevention, the management, the diagnosis, the management, the long-term effects, and so on. I think the most common injuries that I think keep us awake at night worrying about things are knee injuries, in particular, ACL injuries, and then muscle injuries, particularly hamstring injuries. I guess they're probably the three big ones from my point of view. Then there's this groin and back pain, and there's so many issues that are interesting, controversial, lots of new things coming out, and but many of which we've included. I mean, people probably wonder why we have to continually update our textbook, our clinical sports medicine textbook, and that which we do every 5 years or so. So we just published the sixth edition, and really every 5 years there is just so much more knowledge and understanding and research and experience that really needs to be updated every 5 years, and it's a very different book to what it was back in 1993, Dr. Khan, when we first started. And I guess never in our wildest dreams did we think we'd still be doing this 30 years, 33 years later or something. So yeah, the latest books. Maybe you might talk about the first book of the trilogy. We're now 3 volumes. It's got a bit out of hand, but anyway, what about the Foundations book?
Thanks, Peter, and it's a great opportunity. And folks, we will get to the concussion and, as you know, and back pain and things we've touched on. But just we want people not to buy the wrong book by mistake. And so, this sixth edition is, very different in the sense that there's a book focused on students and people learning the principles of sport and exercise medicine, physiotherapy, rehabilitation, massage therapy. And that's the one on the left. You can see the foundations of clinical practice. And that came out about a year ago, and it's done very well. It's in the bestsellers in many countries in sports medicine. And the clue is you've got these sprinters coming out of the starting blocks, and that's a metaphor for people starting their career as a junior doctor or a junior physio. And it's important to have those foundations, because if you don't know how to be a good clinician, if you don't learn from the other clinicians, get the advice from experienced clinicians on how to listen, how to take care of a team, how to be, you do shared decision making, how to synthesize evidence. That's all in this Foundations of Clinical Practice book. And then there are these fundamental sciences that we use in our field, like athlete education, load management, injury prevention. The principles of those are in this book as well. And then we have things like the principles of treatment, like surgery and exercise therapy, principles of rehabilitation, so that in the second book, we're not explaining how to do a mobilization or how to do an eccentric exercise, because that's all been dealt with in the first book. And so we congratulate and thank McGraw-Hill for keeping these prices very competitive, $75 for book one at 440 pages. And then the manual for clinicians, and I'm thinking that most of the folks on this call tonight, will be active clinicians. That's the from head to toe of managing injuries. And I wonder if you want to just share what's exciting about that book, Peter, before we go into concussion.
Yeah, well, we've pretty much had the same sort of basic format ever since we started. Because really, what we're trying to do is teach people or help people how to be clinicians. And so every chapter we start at the head and finish at the toe, and we go through everything in between. And it's really symptom based, because people don't present with a shoulder injury. They present with shoulder pain, or so it's very much practical, clinical stuff. So, and every chapter basically consists of an overview to start with, potential causes of the symptom. Then we look into how to make the diagnosis, so history and examination. And then we talk about, once we've made the diagnosis, the different management, and with the particular focus, I guess, on rehabilitation. We obviously do talk about surgery, but the real focus of the book is on exercise rehabilitation and return to sport. So it's always evolving. I think that the challenge in a book like this is to get a balance between the clinical experience of experts and the research evidence. And we're fortunate enough, we've got, I think, 85 co-authors who have contributed to this book. We obviously oversee each chapter, so that the format, I guess, is consistent. But we've really been able to get the best people in the world to author particular chapters, and we rely heavily on their clinical experience. And then on top of that is all the research evidence as well. So, we don't want to make it totally research based, and we don't want to make it totally devoid of evidence. So we're just getting that balance where we mix the two.
Yeah, and people will recognise great names on both of those covers. So let's go to these topics now. We'll start with concussion, which you suggested was a very hot topic, and we'll go to the knee and the soft tissue injuries and back pain. So you'll try to frame this as questions for folks, and this gives people a chance to put stuff in the chat as well and comments and questions. But would you say, as a question, concussions being well managed at the moment, perhaps, the professional level, the college, and then the more recreational level, what are your thoughts on that, Peter?
Well, I think things have changed a lot in the management of concussion. Certainly, when I started in clinical practice, people didn't really think that concussion was a real problem, that it was a reversible disease, that there were no long-term sequelae and so on. And so it wasn't probably treated with enough respect, really. I think that has obviously changed enormously over the years, and people realise that there is pathology there, and there is it is a condition of concern. I think, we were very, back in the day, we were very sort of gung-ho, that people had been knocked out, and, as long as they'd sort of wake up and answer a few questions, you'd, send them back out on the ground and so on. And so obviously things have changed a lot, and the concussion in sport conferences have played a big role in that. So I think now our diagnosis, we have sort of standard diagnostic tests now that are used all around the world, the SCAT tests. So the consistency in diagnosis. Then there's much more conservative management. There's indicators that you don't any symptoms at all, and you don't return to the game that day, and then you will have a marked period off from sporting activity, and then a graduated return to sport over 1 to 2 weeks. And many of the sporting leagues, both professional and community, now have sort of time-based limits on participation. So if you are concussed, you must not play again for 8, 14, 21 days, depending on things. So that's very different. So I think there's two really interesting. I think anyway, there's two really interesting areas of concussion. Well, there are lots of interesting, but two in particular, I think. One is most concussions are pretty straightforward in that you'll have a concussion. Basically, the athlete will recover reasonably quickly within a day or two of rest, and then gradually return to sport and have no further problems. The interesting ones, there is a subsection. I don't know what the percentage is, but I'd guess probably about 10% of people with concussion who, after 3 or 4 weeks, are still symptomatic, and we call those people post-concussion symptoms. And they present a great challenge, I think, and that's where we've really made progress, I believe. And we have a great chapter in the book by Catherine Schneider, who's really probably the world expert in this area of rehabilitation. And what the secret seems to be is identifying which area or areas have been compromised and causing symptoms. And as you can see on the slide there, that could be vestibular, it could be visual, It could be emanating from the cervical spine. It could be some sort of related to a headache disorder. There are some the mental health issues, and autonomic issues and so on. So it's identifying, where the deficits are in one or more of those symptoms, and then managing that particular symptom or that particular system. So it might be vestibular issues, and now we have vestibular rehab programs that and so on. So I think that's a really exciting approach to the management of these post-concussion symptoms. And so I think there's some fascinating stuff in that chapter. So I guess that's the one really interesting area. The very controversial area, obviously, is CTE, or chronic traumatic encephalopathy, and it's very hard to sort of. There's so much sort of emotion and politics and so on involved in this diagnosis. And I think there's various extremes. There are people who think that everyone who gets concussed is going to finish up with CTE, and then there are the others who think that that CTE doesn't even exist. And as usual, there's somewhere the truth is somewhere in the middle, and that's an area that we explore, particularly John Patricius, who would be known to many of our audience, a well-known sports and exercise medicine physician in South Africa, and he's the lead author of that section of the book, and I think he gives a very balanced view, and that yes, there do seem to be some long-term problems, but the question is, how often and what can we do about it? And the interesting thing is that while there may be these sort of conditions around from people who played contact sports, and in particular we're talking probably about the various football codes, 20, 30, 40 years ago, where the management of concussion was very different. Will our more recent advances in the management of concussion, will they prevent those sort of our long-term sequelae developing? So it's a fascinating area. It's evolving all the time. Every time we come up with a concussion chapter, we really have to change things enormously. But there's some of the interesting areas I think that are in concussion in the current volume.
Yeah, fantastic, and we really have changed those each time because the pace of change in the book. So if we move on to the knee injuries, it's a good way to look at it at the whether we're winning or not. I mean, I remember with your professional football experience, you're in a phase where there was a race to get players back at the quickest time possible from an ACL surgery. Was kind of a mark of honour for the surgeons and the players, and they thought that faster was better. What's your take on it looking back over 30 years now?
Yeah, I mean it's a good point in that there've been all sorts of supposedly major breakthroughs in surgical techniques in particular. We went through the artificial ligaments. We've tried all the different knee reconstruction techniques using hamstring, using patella tendon, now often quadriceps tendons, and then different changes in rehab. None of the sort of accelerated techniques have really proven to be successful. In many ways, we really haven't improved the time for return to sport. So it's still, sort of in some sports, maybe 8 months, in many sports, 12 months. And then still a rate of recurrence that is still, higher than we would like. And no matter how skillful the surgery or the rehab, there still seem to be a group who have a recurrence. So, I think the reason for that is that you can't really change biology, and these tissues take time to heal. As I said, we've tried all sorts of ways of trying to accelerate healing, but we really haven't managed to succeed in that as yet. Now, that's not to say we won't eventually maybe find something. I don't know. But at the moment, I think we have to respect the condition, the pathology, the time to heal. But where we have made progress, I believe, is in two areas. One is in the rehabilitation. So, I think when players now return to sport, still maybe at 12 months or whatever, they are much better prepared to cope with the rigors of high level sport, and so that the rehab program has really advanced enormously. I mean, I remember back in the day when I was first practicing, we would, after the surgery, you'd immobilize them for 6 weeks, and then you spend the next 3 months trying to get the range of motion back that you'd lost because of the immobilization. And so nowadays, obviously, it's early mobilization and a lot of very functional rehab. And I find in my sort of professional football experience, whereas back in the day, the first season back after ACL reconstruction was always a bit sort of, the players would always struggle. They'd never quite get back to where they the sort of the level of quality of play that they had before their ACL injury. Whereas now, I think people just seem to come back and just slot straight in as if they've never missed a season as they have done, and are much better at performance. So that has certainly improved. The challenge, with everything in sports medicine and this ACL injuries and knee injuries are no exception, is prevention. And a lot of work has gone into to prevention. We do see some evidence of success in prevention programs. We have a program developed from our university called Prep to Play, which has been shown we have the evidence to show that can be effective in not preventing all knee injuries, but that focuses on particular exercises in the warm up and particularly techniques in how you jump and land, how you tackle, how you and so on. So I think that's a really interesting area. Surprisingly, the challenge with prevention, and it's not just in ACLs, we might talk about hamstrings later on, is actually getting people to commit to them. I mean, and that goes with coaches and with fitness staff and players. Obviously, they don't want to do those sort of exercises. They just want to go and kick a football or catch a football or whatever. So I think what we need to do better is actually convince our coaches and our support staff and our players of the importance of prevention and the fact that we can markedly reduce the number of injuries such as an ACL, which is obviously a disastrous injury. I mean, 12 months out is for many people, it can be career defining. So we really need to, I think we've got some pretty good programs out there. What we do need is to convince people to adopt them, and that's a lot of that is coaches and support staff to do that. So I think there's some really interesting areas in the injuries. On the surface, we don't seem to be winning because it still seems to take 12 months to come back to after surgery. So yeah, there are some areas we're winning. One of the other interesting areas is do we need surgery at all? I mean, for many years, everyone who had an ACL injury, yep, surgery. The only argument is whether you have surgery straight away or do you wait 6 weeks, 3 months or whatever and do pre-rehab and so on. So that argument has gone on for many years. But interestingly, there's some more and more evidence that not everyone needs surgery, and that each case should be evaluated on its merits, and that some people do quite well with conservative management. Now, there's a particular type of conservative management called the cross-bracing technique that has been developed by a colleague of ours in Sydney called Dr. Tom Cross, who's a sport and exercise physician in Sydney, and his father, Merv Cross, who's a very eminent orthopedic surgeon. And they've developed a bracing protocol, which for certain ACL injuries, not all, but certain that meet certain criteria, has been shown to be very effective. And we've got a sort of a section on that. We're not saying everyone should do that or that the evidence is 100% there, but we feel a part of our role in these textbooks is to introduce new therapies and try and assess them, the pros and cons of using them. And we do have a really interesting section here on the cross bracing technique from Tom Cross. So yeah, there's always things happening in knees because it's such a common injury and it's such a disastrous injury. So there's a lot of emphasis in research and development in these knee injuries. So yep, lots of interesting stuff there.
Yeah, very nice summary, Brookie, of 30 years of studies. And the folks, we've tried to show some examples of the artwork in the book that you can tell we've been very strategic in the sense we're trying to give the reader great value for money by having custom drawn figures and carefully annotated. Those of you that have been with the book for a while will know Vicky Earle's art. And thanks to McGraw-Hill for supporting her genius in our editions of the colour book. So that's the example here. And then the very practical nature, you're talking about the book having a real focus on rehabilitation and being practical, Peter. And that's why we chose to put, a simple rehab program there. So the idea is the clinician can just check this out before they see the next patient. And we're on a call with some other physios, and the younger physios were saying that they really could look at things the night before they have a busy practice load the next day. So speaking of physios, Peter, a quick one before we go to the soft tissues, the hamstrings and the groin, and then the back pain to finish off. Kyati Patel has been kind enough to pop a question in, and he's a sports physio based in the UK, your hunting ground from the early 2010s. He doesn't say what club. He's with a professional club and doesn't say whether he hates Liverpool or not. But the question is an interesting one, and I don't think it's an easy answer, but it's about position-specific return to play. So it's a tough one because you're the greatest sports medicine doctor. So it's like, is it, if you're advising rehab for after hamstring injuries or ACL, return to play, he specifically talks about hamstring. Yeah. There's this idea of position specific. So maybe we'll go on to hamstring and then you can think about that in the background. Yeah. Yeah. Okay.
Sure.
So with the soft tissue injuries, there's been all this work on the soft tissue injuries, but we know from the UEFA data, for example, that players are still getting injured and hamstrings are all over the news from the World Cup to the Premier League. And you obviously had this experience at Liverpool yourself and with Australian team. So, we've just framed this one with the anatomy picture to start off with for people to realise that anatomy is critical and we try and help the reader understand that. But why don't you take it from here on your thoughts on whether we're treating these injuries any better, Peter?
Yeah, it's a little bit like the ACL injuries, isn't it? I mean, despite all the work that we've done and the knowledge and the massively increased understanding of hamstring injuries, which I'll come to in a minute, it's still, a major problem and still the biggest sort of soft tissue injury and probably the most common injury that affects elite athletes. I mean, the ACL obviously has a bigger impact, but the hamstring injury is probably more common. And it's rare that you go a few games without seeing someone pull up with a hamstring injury. And as I said, that's despite all the knowledge that we have, all the prevention work and so on that we do. When we say we have a much better understanding now, see what used to happen, I think was that we just, everyone would have a hamstring, we'd rehabilitate them all the same way, we'd send them all back, at whenever they were symptom free at 3 or 4 weeks, and that a significant number of those would recur. And it was a mystery. We couldn't really work out why did some athletes just always have a recurrence in their hamstring. And we can say the same for calf and other injuries, but let's just focus on the hamstring for the moment. Why did that happen? And it basically it took and I think obviously MRI has helped with all this. It took a sort of rethink of the whole anatomy of the hamstring to understand why certain injuries are more serious than others. And that really revolved around what we call the intramuscular tendon. So we know that muscle injuries tend to occur at musculotendinous junctions, and we always thought that there was a proximal tendon, then you'd have in something like the hamstring, and then you have the muscle, and you have a distal tendon. And so in theory, that's where the injury should occur at the junction between that tendon and the muscle. But we knew that wasn't where they were happening. They were happening in what we thought was the belly of the muscle. So it was this real mystery, and the mystery got solved when we understood the anatomy, and that these tendons actually protrude, if you like, into the muscle and run not the whole way up the muscle, but both a fair way down from the proximal and a fair way up from the distal. And that it's these intramuscular tendons that are the problem. And so the the muscular tendinous injuries that we assume were happening are actually happening at the junction between the muscle fibers and those intramuscular tendons. So that was that was why clinically we'd see them in the belly of the muscle and couldn't understand why that was muscular tendinous. So we sort of got to there, and then we realised that in a certain number of cases, the tendon itself was being damaged, either partially torn or even completely sort of torn. And it turns out that they are the ones that really don't do well, and they take longer to rehab. But in particular, they are more likely to recur. And I think back on famous sports people have had multiple hamstring injuries, and think, well, they were probably because we didn't understand the anatomy and the pathology. So we now thanks partly to imaging, or significantly to imaging, we know about the intramuscular tendon, the T junction, and we've got some great. You talked about Vicky's art. I mean, I think the T junction injury in hamstrings is one of the really challenging areas. And but I must admit, I didn't, wasn't totally clear on the anatomy and the pathology, and we worked with Vicky and came up with these fantastic diagrams that really certainly helped me understand it, and I'm sure they'll help our audience understand it. So it's a fascinating area, and now, I always used to think, well, I don't know why we do, MRIs for hamstring injuries, because the hamstring injury is a hamstring injury, but it's not. There are a lot of differences and subtleties in the hamstring injuries that affect the time out from sport. They affect how aggressively we rehabilitate someone, and they certainly affect the likelihood of recurrence. So our knowledge on hamstrings, has really changed, even in the last 10 years, hugely. And similarly, as I talked about with knee injuries, with prevention is another challenge. And again, it's so important because these are such an important injury, and particularly in professional sport. There's a lot of emphasis now on prevention, and we know that there's really two elements to that. That one is strength, and one is speed. And you've got to get the hamstring strong, and they've got to be able to run fast, and you've got to load them up with speed running. You can't just sort of run at 3/4 pace and then go out and play a game of football and expect to run at full pace. You've got to prepare them to do that. So really interesting stuff. It seems that these intramuscular tendon injuries are getting more common. There's a theory around that maybe it's because the muscles are getting so strong the tendons can't cope with the extra strength. That's possible. So again, we've got a lot to learn. We still haven't managed to reduce the incidence of hamstrings. I sort of look at it that in most of the football codes, the intensity of the game is increasing fairly rapidly. You look at soccer, all the intense pressing that happens now, and the same in the various other football codes. It's much more intense, much faster. And I think our sort of increased knowledge of hamstring prevention and rehabilitation is sort of keeping pace with that increased intensity, but we're not winning, we're not getting ahead of it. So I think we weren't increasing our knowledge, it would be a disaster. But yeah, so huge challenges in hamstring. And as I said, it's very similar in calf. There's a lot more emphasis now on calf injuries, and we have similar intramuscular tendons, or aponeuroses as they call them, in the calf, that are bad news for calf injuries, and we understand that a lot better now than we used to. And again, Vicky's done some great diagrams of calf injuries, and it's similar with quads. So the three big injuries in the lower leg. We have a much better understanding of them now, and I think that the use of that artwork from Vicky really helps a lot.
And if I just make a plug for the exercises, we've really pushed these as a small sample, and there are 1,500 figures in this new book. And we're not here to try and sell books, but just it's good for people to know what the benefits are and the hard work that goes into by the authors showing these different. This is just a small sample of the sort of exercises that are discussed. You can see figure 20.18, 20.19. So Peter, if we just it's 43, so we've got about 7 minutes or so. If we go with the groin briefly, I mean, we've got the groin and showing that there's good rehab on the groin, and then there's just back pain. So, why don't you share the quick take on the groin update when you were part of this Doha agreement, of course, back in 2013-ish, 2014.
Yeah, that was really a game changer. What we call the Doha Agreement. I mean, I think until then, I mean, well, I'm not saying it's all settled now, but there was a lot of confusion about diagnostic entities and labeling, and there were so many different names used to describe various pathologies in the groin and so on. And I think the work of Adam Weir and colleagues really sort of laid that out very clearly, I think, and led to a much better understanding. And this famous image that you can see on the screen there, I reckon that's probably Vicky's finest work, and it was certainly the work that has been probably quoted most and used most in lectures. And I mean, every single lecture on groin or hip or anything that I've ever been to, I think in the last sort of 13 years or so, shows that image, and it's really sums it up very nicely about the different areas, the different pathologies, and so on. Um, so a much better understanding. Again, I think there's both prevention and treatment that where we've improved things dramatically. I think the use of the Copenhagen exercises in groin pain, a bit similar to the Nordics in hamstrings, very specific exercises both to help in prevention. So most, elite football teams now would was part of their warm up and would do these prevention exercises for both hamstring and groin, and then also the rehabilitation and return to sport and so on. And we do seem to be winning. I think that we're winning in groins. They're not nearly as prevalent in sport. They're basically an overload issue, really. And I think we've you talked right at the start, I think, Karim, about the importance of load, and that's something that we really emphasise in both the books, really, the foundations book and the injuries book, about the importance of managing load. And I don't think I heard the term load, in my first 20 years in sports medicine. I mean, it just wasn't a concept that people really understood. And I think now it's become so important as I said, both in prevention and in return to sport as well, and so on. So really interesting. I think in groins, the question you asked there, is exercise rehab the first line? It certainly is. I mean, I think I think we've gone down the surgery track, we've gone down the injection track, and then look, there is a small role for both of those, but really, exercise rehab is the key to the management of pretty much all soft tissue injuries, really, and post operative as well. But I think it's the key, and we should be focusing on that really. And again, there's some great exercise rehab photos of various exercises, and there's a model there as a young physiotherapist who plays on my football team. As we roped him in for the day, and we've got lots of good rehab exercises there that can help in the management of groins. I think that's one area that we're probably not making a lot of progress in ACL and hamstrings, but I reckon we're doing okay in groins.
Okay, so two neutrals and a win. The great Dr. Mosley there, I think, as well, groin expert in that photo, working with that person. So, if we can do a good job in 5 minutes on a simple problem like low back pain, Peter, why don't you do your best
Easy
there?
problem. Yeah. Look, I mean, again, it's a massive problem in society in general. Low back pain. I mean, there's no doubt about that. It's the most common sort of a musculoskeletal disorder. And virtually everyone at some stage of their life, I guess, has had low back pain. And again, our understanding has changed dramatically. And in our first editions, we were treating low back pain largely with electrotherapy and some manual therapy. Whereas now, I guess, like most of these rehab programs, they're largely exercise related. Although I still think there is a role for manual therapy. But there's a lot of controversy in low back pain. There's the school of thought that it's at one end of the spectrum, if you like, that people say it's all mechanical and you need mechanical solutions, and then at the other end of the spectrum, there's the sort of psychosocial aspects of chronic pain, and we're fortunate enough to have Peter O'Sullivan and some of his colleagues who have really been the sort of pioneers of that concept of biosocial aspects of chronic pain, and they describe that very well in this the low back pain chapter. But I think it's important, and we've done this in the chapter, is to differentiate. Certainly chronic low back pain is a massive issue in our society, but it's not as much of an issue in sport. I mean, in sport, acute low back pain, or acute being short history or sudden onset rather than severe, low back pain is the issue, and so we've separated a little bit the approach to those two different types of back pain, because I think they're managed quite differently. Now, they may overlap if the acute low back pain becomes chronic, and then some of those other components come into it. But Dr. Larissa Treese, who's one of the doctors at the Australian Institute of Sport, who's just doing her PhD now after many years of clinical practice, and Kelly Wilkie, a physiotherapist who's worked with the Australian rowing team, they've done a great section in the book on the management of acute low back pain, and hopefully, get to the stage where it doesn't develop into the chronic low back pain with all its sort of complicating issues. So that's been a really interesting, I guess, demarcation between the two different types of low back pain. And obviously the imaging has played a role in the management of low back pain. But I think it's really important to always remember the concept of you treat the patient, not the MRI. And so their section on acute low back pain is very very simple and straightforward, but very effective. So there's also we have an interest particular in because of our cricket background. It's a crazy sport that the Commonwealth countries play, but also in other sports as well, and in pars stress fractures and stress fractures of the pars interarticularis, which is an epidemic in cricket fast bowlers, and common also in other sports where hyperextension and rotation, things like gymnastics and high jump and so on are big issues. So that's an area that we've updated again. We've really got some great people who've worked with all the Australian cricket fast bowlers over years, and so have a great understanding now of both the diagnosis and the management of these pars stress fractures and return to sport. That's a real thing. I think that we've probably changed the emphasis of over the years, Karim, is the return to sport program. I think that's always been the surgical approach is, well, I fixed it, you can go back to sport, sort of thing. And obviously we realise now that it's got to be a graduated return to sport. So we have a real emphasis on that in all the chapters in the book, as well as talking about the principles of it in the Foundations book. So yeah, look, obviously I can go on for ages. I probably have gone on for too long as it is, but there's some really exciting stuff, and I think you can tell that we're passionate about some of the changes that we've made in this edition of the textbook. You sort of when we embark on each new edition, you sort of think, not much has changed, and then once you get into it, you realise, my God, so much has changed in 5 years, and both from what we do clinically and what the research shows. So it's been an interesting journey.
Great job, Peter. So, quick ones to sort of the quick zingers to finish. We'll finish in the 55. So, just a quick, it's like the one shot. Dry needling. You're a fan. Found it effective. What would you say?
Yeah, look, I find dry needling very effective. I mean, I think it's not the only way to manage sort of these tight sort of soft tissue bands and trigger points and so on. You can stick your thumbs in, your elbow in, or whatever. But I find dry needling very effective. The research is a bit equivocal. Very hard to do research on dry needling. We did a project ourselves with sham needling and so on. But I think it has a role. And I think that we cover various adjunct sort of treatments in the text. But yeah, I'm I'm definitely in the dry needling camp, and I know a lot of physical therapists are increasingly using dry needling as part of their management of just sort of more chronic type low grade pain.
That's a yes. And yeah, you are a doctor, and you've done a great job. I think it's important for folks to know you're very respected in Australia if you work with diabetes, and type 2 diabetes is a global cause, and you need your own webinar for the whole webinar on that. But the role of food for inflammation, if clinicians are struggling with someone who has inflammation here, inflammation there, they seem to have all these conditions. Could you point them to some tips?
Yeah, look, that's something that again I didn't understand until relatively recently. That so many of our conditions that we treat as doctors and physical therapists are inflammatory in nature, and there are certain things that we know accentuate inflammation, and other things that can reduce it. And diet is one really interesting area, and I've become increasingly interested in the role of diet and in particular, sort of what I'd say to summarize it is a real food diet, rather than trying to eliminate some of the processed and ultra processed foods that do seem to contain inflammatory components such as sugar and vegetable oils and certain grains and so on. And clinically, we've had some really great successes in managing inflammatory conditions with diet and improving diet. And we've just finished a research project looking at diet and knee osteoarthritis with some encouraging results and so on. So I think that's an area that we'll hear a lot more of over the next few years. Is this role of diet, other factors that affect inflammation, things like sleep. I think we haven't had nearly enough emphasis on sleep. And obviously, smoking, alcohol, inactivity, and sunshine is a really interesting area looking at the role of sunshine and not just vitamin D, but nitric oxide and so on in the management of different conditions. So, yeah, there's still lots of stuff we don't fully understand, but there's some fascinating areas for the future, I think.
Fantastic. I'm headed back to Yara. So great job, Peter. It's great. Always learn stuff.
Thank you so much to both of you, Dr. Buckner and Dr. Khan, for such an insightful and engaging presentation. For our audience, you can continue to submit your questions in the Q&A box. And before we move into the Q&A, I just want to reiterate that, yeah, here we go. So the latest 6th editions of the acclaimed Brukner and Karim Clinical Sports Medicine series, Clinical Sports Medicine Foundations of Clinical Practice, and also Clinical Sports Medicine Managing Injuries are now already available. Together, these titles provide a comprehensive resource covering the foundations of clinical practice, especially for clinicians early in their careers, and also the diagnosis and management of sports injuries for clinicians and professionals. These titles feature a lot of visuals, as Drs. Bruckner and Khan already highlighted, and they also include a lot of practice pearls and much more. These titles are also available digitally on Access Physiotherapy, one of McGraw-Hill's Access platforms. In addition to the full textbook content on Access Physiotherapy, users can also explore the Bruckner and Kahn video and audio collections, along with a wealth of additional resources designed to support education, clinical decision-making, and also evidence-based sports medicine practice. At this moment, I'd like to bring up some questions forward to our speakers. There was a particularly interesting question on how you can balance evidence-based guidelines on managing injuries with the reality that athletes in high performance environments may be under pressure for a rapid return to play?
Yep, tough question. Karim, you want to have first crack at that?
Just so I'm clear, the tension of what the guidelines are and what you would do ideally and what you have to do in real life, is that the tension?
Yeah.
And I'm seeing the other question in the chat about the yeah. I mean, Peter, I'm reluctant to do a clinical answer now that I've retired from clinical practice, and so why don't you go with that one, Peter, please?
Yeah, look, I think it's a very reasonable question. I mean, I think obviously elite sport is a little bit different. Because there's a lot of pressure to get people to perform. And again, it's always a compromise. If you wait, I guess till every professional athlete is 100% fit and healthy and has no niggles or pains or anything like that, they probably wouldn't play very often. So it's a matter of balancing. And I think every individual case is a separate decision. I mean, you've got to weigh up. Obviously, you've got to respect the pathology. That's the first thing. I mean, if you've got an injury, you can't ignore the pathology. But there are certain, and I think particularly with clinical experience, there are certain people who can maybe tolerate different injuries better than others. So I think there is a component of that. There are certain injuries maybe that you can play with that maybe other injuries are too risky to play with. So there's all these different factors you have to take into consideration. How important is the event? We've got the World Cup soccer on at the moment. Well, I'm sure there are people there who I noticed that one of the England players has got a calf injury and had to withdraw. Well, that must have been a pretty significant injury to make them do that. I'm sure there are other people with minor injuries who are prepared to sort of continue on and still be quite effective. So yeah, it's a really I think that's almost it's the biggest challenge of working in professional sport is getting that balance right. And obviously, on the one hand, you've got the coach and the player, pushing, play, and you've got to protect. You've almost got to protect them against themselves. So, yeah, very challenging.
Thank you. That was a very clear explanation, and indeed, it is finding that point of balance in between getting these athletes back into play while making sure you're not risking their well-being. Another question, also probably on the clinical side of sports medicine, asking about the technology and digital health and how it might influence managing injuries or even preventing them in the coming future.
Yeah, I think one of the big advances has been in wearables. That a lot of athletes and particularly sort of I guess people in the fitness industry are using wearables to measure. And we talked a bit before about load, and they're really measuring load. And obviously the one that comes to mind is the GPS, which is used very widely now in not just in elite sport now, and even in in lower levels of sport. So I think that's only going to get sort of more sophisticated and more advances in the knowledge and understanding through these wearables. And so I see that as a big area of the future. Becoming more sophisticated, and even the GPS, we now know a lot more sort of broader range of information from the GPS than we did when they first came on the scene, and so on. So I think they're really important in managing load, and that can be quality and quantity, so speed and endurance. And again, that plays a role as the question mentioned in both prevention and in rehab and in return to sport. So yeah, big role for those sort of wearables, I think, and data. I love data.
Good to know. Um, I think I'll address to you one more question. It's related to the new sixth edition. So someone is asking, you've mentioned the updates in the sixth edition, the major updates, and if a clinician could take away just one key message from the new edition, what would you hope that would be?
Peter, I was going to ask you that one as well. So if we do one each, maybe, is there's, I think, the commitment to exercise as being the fundamental thing that, you know, there was this electrotherapy phase in the 90s. Obviously there's the promise of orthobiologics, but that promise isn't here yet. And so I think the clinicians should feel comfortable. And actually, I'll add that there's this mechanotherapy, which is a whole concept of itself, but the idea of loading tissues is proven at the cellular level to promote tissue repair. And so I think when, for a young clinician, they're being hit by a lot of different pressures to do different treatments. The core, I'd say, of this new edition is that do careful assessment, and that's why we have so many photos of showing, how to assess carefully. Find out what the problem is with your clinical skills, and then have really focused rehabilitation, strengthening, range of motion, which is the old basics, right? Like it's someone saying, well, wasn't that the fundamentals in the 1990s? Well, that's biology, and the biology is that if you address the right problem with appropriate load progression, it will be good. So it's a simple story, but I'd say that by knowing the world's leading clinicians, which I do, for the young clinicians, that's what these fancy clinicians do. They do the basics really, really well. So over to you, Peter.
Oh, well, just very quickly, I know we don't have much time. I think probably prevention. I think that's it's become so important now, and we're talking both primary prevention but also secondary prevention. Preventing re-injury. Getting the injury rehab to the point where you're not going to get a recurrence of the injury. So yeah, I think that's been a big focus of the last couple of editions, really, particularly this one.
Yeah, and if I may, that's where we have the QR codes to point people to these. Yeah, we don't think that you can get everything into two textbooks, but we want us to give people the essentials so they quickly get up to speed with what they can trust. And then we point them to resources, and that's where the QR codes have been fantastic because people could find stuff on the internet, but there's a million bad things on the internet, and our QR codes can be trusted.
Absolutely. Well, it's been very insightful and very engaging, but as we're approaching the end of our time, we hope that you all found today's session both valuable and insightful. A quick reminder that the recording of the webinar will be shared with all registered participants, and you'll also receive a short survey afterwards. We would really appreciate your feedback to help us on improving future events. On behalf of McGraw-Hill, I would like to sincerely thank Dr. Peter Brukner and Dr. Karim Khan for sharing their time, the expertise, and obviously their valuable clinical insights with us today. And thank you to all of you who joined us from the different parts of the world and for your continued engagement in advancing sports medicine, both in education and practice. With that, have a wonderful day or evening, everyone, and we look forward to welcoming you in our upcoming events. Thank you so much.